All right, everybody. All right, I think we're going to go ahead and start. My name is Christine George. I am a third-year pediatric resident.
And I'm Ellika Rasooly. I'm a first-year pediatric resident.
And Dr. Natalia Jaimes is on her way, and she'll be joining us here shortly. Today we're going to be talking about an article about the use of a smartphone app to assess neonatal jaundice.
And you don't have any disclosures,
that's what I'm about to say, is that we have no disclosures, as is also on our first slide. Okay, and with regards to our objectives, they're also in front of you, but we're going to be basically going through how do we assess this, how do we come up with a clinical question, assess it using a critical appraisal tool, and then go over various concepts related to the article. Okay. So the first thing that we're going to talk about is the clinical context here, and that being neonatal hyperbilirubinemia. All right, so as many of you already know, very common thing that we see in newborns. It's considered to be clinically significant, meaning greater than 17 milligrams per deciliter in approximately 10% of term newborns and about 25% of near-term newborns in the United States. Now, that prevalence is actually quite higher in many other countries, especially those that have a higher rate of G6PD deficiency. And of course, why do we care? Is because with really high bilirubin levels, there's a risk for various neurologic sequelae with that, including acute bilirubin encephalopathy, then progressing to kernicterus. And of course, we treat initially with phototherapy in order to help prevent that rise. So gold standard test for looking for neonatal jaundice, total serum bilirubin. Collect with a blood specimen, heel stick, a little painful, sometimes inconvenient. At our facility, the actual test itself costs about $30 to run, but that's not including actually the cost of the collection of the specimen and any transit. Typical screening that's done is transcutaneous bilirubin, and that's based off of a concept known as reflectance spectrophotometry. And it's nice in that it's a nice point of care tool, but it does tend to underestimate the serum bili, particularly when that serum bili is higher. And there are some other types of costs associated with it. The bilirubin meter itself can cost anywhere from $5,000 to $7,000, and then you also have to keep up with maintenance, and then each of those calibration tips that you have to use every time you use it is about $6 each. And then, of course, there is this visual inspection has been used for many years, but it is very notoriously unreliable, and ends up being basically a 50-50 chance as to whether or not you're actually going to be able to detect clinically significant jaundice versus just normal physiologic jaundice. So, kind of in framing the article here, the evaluation of neonatal jaundice is either expensive with transcutaneous or serum bili, or unreliable with visual estimation. And something that is a neat concept, thinking about how smartphones, which are everywhere, all over the world today, might offer an inexpensive and available option for the diagnosis using various concepts within digital imaging. And this leads us to our article on the use of a smartphone app to assess neonatal jaundice. This was just recently published in the Pediatrics Journal in September, and run with the lead authors coming out of the University of Washington. In terms of our PICO question, our population is our healthy term, near-term newborns who are less than 7 days old. The diagnostic test that we're going to be looking at is the BiliCam smartphone application. Me comparing that to a total serum bilirubin, which is the gold standard, as well as some comparison to the standard screening method that's used with transcutaneous bilirubin. And we're going to be looking at how likely are we able to predict that the serum bilirubin is going to be in the high-risk zone on the Lutani Nomogram, or if the serum bilirubin is greater than or equal to 17, which is determined, again, to be that clinically significant threshold. It's a diagnostic question, and you use a diagnostic accuracy study. All right, now we're going to do a little, talk about the index test, which is, again, this BiliCam smartphone application. All right, so the main concept, and you have an example of the cards that were used, these color calibration cards that were used as part of this study. How the app works is that you basically take 6 images using your using the iPhone 5S camera. And through the app, there's 3 photos with flash, 3 photos without flash, and this card is centered over the newborn sternum. And then that image data is then sent via the internet into a server, and then there's a lot of fancy schmancy background stuff called the machine learning algorithm that ends up being popped out. All right, so step 1. You're going to enter in the date of birth as well as the time of birth of the patient. And then, next slide. This is an example of kind of what this app actually kind of looks like, where obviously that's not a real baby, but the card is put on the center of the sternum, and then the app opens up and it focuses and then automatically takes 6 different pictures, 3 of them that are with flash, 3 of them that are without flash, again, of the sternum, the skin that's centered on the sternum with the calibration card surrounding it. All of that data is then sent to the servers and broken down into several key components. They're looking at various components of the color in terms of the hue, saturation, and gamma associated with the light that's then, the light and color that's reflected off of the jaundiced skin. And then they're balancing that against the known entities that are in the color card that are surrounding it. Then take that and they extract certain characteristic features within that data and apply anywhere from 7 to 12 different algorithms, regressions within a larger algorithm that end up allowing us to predict or determine an approximate bilirubin estimate.
Okay, so now I'm going to continue on with study design.
All right, so study design here. We have our settings. All right, so this study took place at 7 different institutions across the United States. Obviously, I have a map here. We have institutions in Pennsylvania, Missouri, Utah, California, Arizona, as well as Washington. Enrollment, our inclusion criteria, again, we kind of got some of this from our PICO question of healthy newborns that were less than 7 days of age, and they had to be greater than or equal to 35 weeks gestation. That's that term, near term category. And the only kind of global exclusion criteria were those that had previously received phototherapy. Now, something that was interesting about the study is, so they did have additional criteria, but that seemed to vary by site. So certain individuals that were enrolled at 2 institutions, they were enrolled at less than 24 hours of age, and then they were then collected BiliCam images as well as serum bilirubin was collected at when they were 3 to 5 days old at a follow-up visit. Then at 2 institutions, it was the data was only collected if they were, quote, clinically jaundiced. In 2 other institutions, they did both a, quote, routine screening on newborns that are in their nurseries as well, or if they were clinically jaundiced. Data collection, some key points that were collected in terms of race and ethnicity of the infant, obviously the date and time of birth. We wanted to know, okay, so what was the collection date and time for the serum bili as well as the BiliCam bili, and then what was those 2 estimated values. And then as described within the article, if it, quote, attempts were made to obtain BiliCam images within 2 hours of the blood draw. There was also some institutions that provided data on also correlating this with transcutaneous bilirubin, and 3 institutions noted that they collected for, quote, virtually all participants at the time of the blood draw for the serum bili, and then at one institution it was collected for selected newborns. That's the only information that we're given. Then some just key stuff about analysis that we'll get into a little bit more detail later. It's analysis based off linear correlation, the Bland-Altman plot, sensitivity and specificity, and kind of these 2 big outcomes that they were looking at. Number is either, so can the BiliCam predict high total serum bili using 2 very commonly accepted and used decision rules that we use for the actually transcutaneous bilirubin, since it's a somewhat similar concept in terms of how the data is extrapolated. First of those being, if it was greater, so if the value that BiliCam produced was plotted on the serum bilirubin chart, Nomogram, and it was greater than or equal to the 75th percentile, which is that high intermediate risk zone or higher, that would predict that the actual serum bili was in a high risk zone. Because again, thinking about this in a way that's, we're saying that BiliCam is somewhat similar to transcutaneous, it would underestimate the bilirubin when the bilirubin is at a higher level. And then the other outcome is whether or not, if we say that if the BiliCam gets a level that is greater than or equal to 13, will that predict that the serum bili is actually, greater than or equal to 17?
Okay, so I'm going to continue on with the study results. So the first graph we have here is a linear correlation graph, and it's looking at the relationship between paired total serum bili and BiliCam bili values in our 530 newborns. So on the y-axis we have the total serum bili, and on the x-axis we have the BiliCam bili values. Each individual red dot is our each newborn, and the line going through the red data points is the linear regression line. As you can see here, the data points are very close together, and they're going in the positive direction. So as the BiliCam bili value increases, the total serum bili increases. The correlation coefficient is calculated as positive 0.91 with a 95% confidence interval of 0.89 to 0.92. So they also looked at the correlation coefficient by ethnic group. As you can see here, the white population had the highest correlation coefficient of 0.92, and the Asian American population had the lowest of 0.88, but still very strongly positively correlated. So moving on, this plot is called the Bland-Altman plot, and the Bland-Altman plot looks at, identifies or evaluates the agreement among 2 different instruments, and in our case, it's looking at the total serum bili and the BiliCam bili, and it also identifies any systematic differences. It looks at bias. So actually, before we look at the mean difference, on the y-axis, we have the difference between the BiliCam bili and the total serum bili, and on the x-axis, we have the average of the BiliCam bili and the total serum bili. The horizontal solid line here is the mean difference, which is 0.01 plus or minus 1.8 milligrams per deciliter. And the dashed horizontal line is called the limits of agreement, or the 95% confidence interval, or 2 standard deviations from the mean. And that is minus 3.6 to positive 3.6 milligrams per deciliter. So they calculated that 92% of the BiliCam bili values were within 3 milligrams per deciliter of the total serum bili. And 73% of the BiliCam bili values are within 2 milligrams per deciliter of the total serum billy. So this table here looks at the utility of the billy and also they included the transcutaneous billy as screening tools to identify newborns with high total serum billy values. So this table can be kind of confusing because it looks at sensitivity, specificity, positive predictive value, and negative predictive value. And they were looking at 2 different outcomes. The first outcome is the billy or transcutaneous billy greater than or equal to the 75th percentile on the Buchanan total serum nomogram to predict a total serum billy in the high-risk zone. And the second outcome is looking at billy or transcutaneous billy level greater than or equal to 13 to catch or to predict a total serum billy in greater than or equal to 17 milligrams per deciliter. So looking at the sensitivity in the first outcome, between the billy and the transcutaneous billy, they're pretty much equal, 85 versus 81%, and it's not a very good sensitivity, only really 85 and 81%. Looking at the second outcome, the sensitivity is 100% for both billy and transcutaneous billy. For the specificity of the first outcome, billy had slightly less specificity, but again, not very good, compared to the transcutaneous billy, 82. And for the specificity for the second outcome, they both were very similar, but again, not very good specificities. Positive predictive value, they have low positive predictive value. Billy has slightly higher at 32% versus 19%. And for the second outcome, again, very low positive predictive values. Billy has slightly higher, 20% versus 13%. Negative predictive value for both outcomes is high, is 97 and 98 and 100 for the second outcome. So although we're going to make our own conclusion about the results at the very end, I just wanted to include what the authors mentioned. They stated that the billy provided accurate estimates of total serum billy values, demonstrating that an inexpensive technology that uses commodity smartphones could be used to effectively screen newborns for jaundice. So now we're going to move on to the critical appraisal. So we're going to talk about, are the results of the trial valid? And we're going to talk about the internal validity. So the first question is, was the diagnostic test evaluated in a representative spectrum of patients? So is this diagnostic tool, is this billy application diagnosing all spectrum of disease? Is it looking at normal babies? Is it looking at babies with mild jaundice, moderate jaundice, or severe jaundice? So in order to, a way to do that is to look at the age and also the total serum billy. So are they looking at not just babies in the first day of life or the second day of life? And so they reported a mean age of 75 plus or minus 29 hours with a range of 12 to 163 hours old. And they also reported a total serum billy of 10 plus or minus 4 with a range of 0.6 to 29 milligrams per deciliter of the total serum billy. 12.5% were in the high-risk zone on the total serum billy nomogram, and 15% had a total serum billy greater than or equal to 15 milligrams per deciliter. So they only reported mean for age and total serum billy. They didn't report the median or the interquartile ranges, and that would have been useful to have those to better understand the distribution, because mean can be more affected by outliers, and mean can be skewed. So it would have been useful to have median and interquartile ranges. Also looking at another way to answer this question is is to see if they looked at various ethnic groups. And they looked at, as we saw in the other table, they looked at various ethnic groups, as you can see on this table here. And although they had a higher percentage of white population at 55%, they still had a very good representation from the other ethnic groups. As you can see, African American and Asian American at 21% and Hispanics at 26%. So continuing on with the internal validity, do the authors include information about those who satisfied inclusion criteria but didn't receive the diagnostic index or reference standard test? So those who didn't receive the BILI-CAM app or the total serum BILI. And so this is yes and no. So they didn't tell us about those who did satisfy inclusion criteria but weren't approached to either partake in the study, or those who declined to partake in the study. They didn't include information about that. Also, as Christine mentioned, there were site-specific inclusion criteria were a bit vague. But in the 580 newborns who received BILI-CAM images, they included that 8 had missing matching total serum BILI levels, 4 had no matching total serum bilirubin levels were obtained, 2 had lab issues, 2 parents declined blood draws, 3 had issues with the consent process. So if you subtract all those, you get 569 participants or less. So do the authors include how indeterminate results, missing results, and outliers of the index test were handled? And so they stated that of the 569 participants, 39 newborns didn't receive complete BILI-CAM images. And we don't know, they don't explain why these 39 newborns didn't get the complete set of images. This could have been an issue with the technology, an issue with lighting, the positioning was wrong. They didn't go into detail. They didn't have internet connectivity. We don't really know. They don't go into detail. So if you subtract the 39 newborns who didn't get the complete images, you have 530 newborns who got both the BILI-CAM BILI and the total serum BILI. So was the reference standard clearly defined, independent, and valid? So it was clearly defined. It was defined as the total serum bilirubin. It was independent. So the total serum BILI was done independent of the results of the BILI-CAM BILI. But in some sites, patients got total serum BILI and BILI-CAM BILI based on visible jaundice. So it was dependent on visible jaundice. They received the total serum BILI and BILI-CAM based on jaundice. But the total serum BILI and BILI-CAM BILI was done independently of each other. And the reference standard, which is the total serum BILI, is valid because it's the gold standard of how to diagnose hyperbilirubinemia. Was the reference standard applied regardless of the index diagnostic test and vice versa? And this answer is yes. So the total serum BILI was applied regardless of the BILI-CAM BILI and vice versa. Was there blind comparison of the reference and index test? And this is no, and the authors didn't mention that the total serum BILI and the BILI-CAM BILI were blinded to each other, and this decreases the validity of the study because a nurse or a physician could get the results of the total serum BILI and could repeat the BILI-CAM again to try to match the total serum BILI, so they weren't blinded to each other. They did mention that we also don't know if the BILI-CAM was collected before or after the total serum BILI. They did mention that 92% of the total serum BILI and BILI-CAM BILI were collected 2 hours apart, and 3% of the total serum BILI and BILI-CAM BILI were collected between 2 and 3 hours. So the last question under internal validity is, was the test validated in a second independent group of patients? And this is no. So they collected data, as Christine mentioned, from the 7 different sites around the country, and it was combined into one. It was pulled into one data set. It wasn't analyzed by subgroup, but it was not. They did not perform a separate. Did not perform the study in a second independent group. So it still needs to be validated in a separate population, which was never done.
But it's planned.
Right. So, moving on.
All right. Okay, guys, yeah, sometimes. So now we're on to some more detailed stuff about the results. And I know sometimes this can be a little bit dry. We'll try to make this as dynamic as, yeah, well, we'll try. So, how accurate and precise were these results? All right, nice and easy in that there's only really one question in terms of, well, what kind of test did they even present, in terms of what results did they present? All right, and so we're going to go through each of these. We're going to do a little quick review, though, to make sure everybody is on the same page of understanding these concepts. So first is we have a linear correlation coefficient. And as Dr. Rasooly had already kind of showed and talked about, we have this very nice correlation graph here. And within this study, looking at comparing the serum bilirubin versus the BILI-CAM values, there's a pretty strong positive correlation here between the two. So again, correlation, looking at strength and direction of correlation. So in terms of whether it can be positive or negative, or it can be strong, the greater it is strong, the higher it is away from 0. And down here we have examples of kind of different positive versus negative correlations and how that would look on the graph. Over here we have a high positive correlation around 0.9 being very similar to the correlation that was obtained for the values within this study. However, as you'll know, correlation does not equal, it is just one piece in several things that we have to look at, looking at a diagnostic test. All right, so next we're going to look at this called a Bland-Altman plot, and the subsequent analysis. We already talked about this a little bit, but again, we're looking at, the big thing is mean difference, limits of agreement. All right, so it's just another way to plot this data out and to look at it and compare, okay, are there tons of outliers on either side? And then in addition, something else that they can tell you is another type of bias, in looking at, so you can see there's a little bit of a slope down here. So this aligns with kind of the thought that the BILI-CAM BILIs do something that's somewhat similar to what transcutaneous bilirubins do, meaning they tend to underestimate the serum BILI at the higher levels versus, but can potentially overestimate them at lower levels. Sensitivity and specificity. All right. Again, already went through these. Generally, our sensitivities were better than the specificities. All right, guys, remember this snout and spin. All right, so our sensitivity, high sensitivity, and you have a negative result, then you can feel pretty good that they don't have the diagnosis or the condition that is concerning. And then the specificity, if you have high specificity and you have a positive result, you can feel pretty confident that they do have that diagnosis. And here's just two different kind of graphical depictions of, so high sensitivity being a low false negative rate, and that's very good for screening tests in particular because you really don't want to miss. You're pooling a big group of people, and you don't want to miss somebody who has the condition because you plan on doing something else that will kind of filter them out. even more. Then we have our positive and negative predictive values. All right, again, here are, you're like, well, okay, so our positive predictive values are kind of lower and our negative predictive values are high, but what the heck does that mean? So, again, positive predictive values, proportion of people that are positive and have the condition, and then negative predictive value being the proportion of people with a negative test who don't have a condition. And so, very similar, but in the end, it's related to prevalence. So, predictive values are dependent on prevalence, or that pretest probability is what we'll often use for that. There's two kind of equations of how prevalence it kind of gets incorporated into some of the calculations that here are listed on this slide. There's a graph also kind of showing basically as the prevalence of a certain condition increases, that actually tends to increase your positive predictive value and decrease your negative predictive value. And in general, we're talking about, so I said, if you're looking at term newborns, 10% of them, which it's still a decent amount, but it's still not an extremely high prevalence, end up having the disease, and so it's not even physically possible for you to get very high positive predictive values, and you're pretty much, you should be almost guaranteed negative, a good negative predictive value. All right, and the culmination question, okay, great. Now, what the heck do I do with all this information? And how is this actually really going to help me and my patient in where I work? So the external validity and applicability. A couple more concepts I need to throw at you guys just to make sure that we understand. Pretest probability. Again, it's used oftentimes synonymously with prevalence, but it is not the exact same thing as prevalence. Pretest probability actually is looking just at a smaller level. You're looking at the more individual level of how suspicious is the clinician that a certain patient has a disorder. So it could potentially be higher than the prevalence if there are other factors that come into play, for that particular patient. But in general, if you're just kind of dealing with a very broad group, using the known prevalence is the way to go. Post-test probability is in the revision of that after you've done your test or your physical exam finding that then should move you along your diagnostic path. And then connected to all of that is your likelihood ratios. Those and this is where we bring in that sensitivity and specificity, and those become important in terms of how likely is it that this test is going to tell me that this patient has a disease or does not have a disease. And then we have this nomogram. I know we see it in a lot of books, and then you just kind of go, oh, I don't know, that thing looks complicated and crazy, and I don't need to use that. Like, why would I need to know how to do that? Well, it's on the boards is the first one, but it's also a lot easier than you would think in terms of trying to use this tool to help determine whether or not a test is good for a particular patient. Sorry, a couple more things about the likelihood ratios. Larger number, in terms of a likelihood ratio that's closer to something like 10, that means that there's a big change, that this test really, really helps you in terms of saying that, yes, they have a certain disease, versus a negative. Within the negative likelihood ratio, a number closer to 0, that's what tells you has a larger magnitude in terms of that jump from your pre-test probability into a post-test probability, one way or another, in terms of whether ruling in or ruling out a disease. So, will they change my management? Now we get to do a little bit of math and a little bit of drawing. So we talk about our first outcome. Again, so if our Billy-Cam-Billy ends up plotting at that high intermediate risk or higher on the nomogram, will that predict a high-risk zone? And we've already talked about the sensitivity and specificity of 85 and 75%. All right, post-test probability. Again, we're just going to go with the prevalence, and we have our then we're able to calculate our likelihood ratios based off of sensitivity and specificity. Now, these were not presented in the paper itself, so this is something that you do have to do on your own as part of your critical analysis of this type of paper. And you do that, ends up coming up at the positive likelihood ratio is 3.4. So it ends up being connect the dots. Start off, say 10%, then you connect it in at the likelihood ratio in the middle here at around 3.4, and you just then keep drawing a straight line and see where it lands. And this ends up being at about 27%. So small increase in terms of that you're trying to rule in that diagnosis. And then your negative likelihood ratio is 0.2. Same kind of deal, where you end up, start at 10, see where it intersects at 0.2, continue to go down, and so you actually do make some better gains here in terms of helping to rule out that diagnosis by utilizing this rule within this application. And then we get even actually some better results here with the second outcome in terms of looking at saying, all right, if our BILI-CAM is greater than or equal to 13, is that going to predict a high BILI, a total serum BILI? Again, we have this higher sensitivity, so we would predict that it would help us in terms of ruling out that diagnosis. Our likelihood ratio ends up being 4.2. Do our little lines there, and we get, you know, a little higher gain, say, to 32% from 10%. And then, but our negative likelihood ratio, again, we had 100% sensitivity. Now, I would just like to word of caution of this, you know, whenever anything is 100% or anything is 0, like that's, you always got to be just a little bit wary and wonder, all right, was my population size big enough that that this truly is as sensitive, you know, as what this is saying, but this is reassuring in that regard. Based off of the population size, because basically, you know, we're just like, I can't even really make it. It's all the way down there if you say 0 in terms of that likelihood ratio. So this, they didn't miss a single BILI, total serum BILI that was higher than 17 by using this rule. So will they be better off? Well, again, similar thing with the transcutaneous bilirubin that you're supposed to, you know, should decrease the number of unnecessary blood draws. And then you talk about possible cost savings. Again, the bilirubin meter for transcutaneous is $7,000, and then, you know, it can break, and then, you know, you're waiting on maintenance to then take care of it, and then you also have the cost of each of those calibration tips. And oftentimes you're still then stuck actually poking them and having to get a total serum BILI. And there's an interesting thought about using these in resource-limited areas. As many people who have done work internationally can say, cell phones are everywhere. I mean, I personally spent 3 months in Mali, and while we didn't have electricity and running water for most of that time, there was an hour every day where they would turn on the generator, and everybody's cell phones would be charging during that time, but I still had to go to the river to get my water to bathe in. This is kind of the reality of a lot of places that are, you know, in kind of these resource-limited, resource-poor areas. So you theoretically have a smartphone and be able to access data in some way, shape, or form, and not have to buy an expensive machine that would require upkeep. All right, and then the last question here is, were these methods described in sufficient detail to permit replication? Nah. I mean, to be fair, there's a lot of back-end stuff. There's a lot of very computer science-y algorithm back-end where even if you were to have gone through all of it, it would have been a dissertation and a lot of algorithms that we would have honestly not, I think, really would not have appreciated. They have submitted this app and the whole background process in for a patent, which is still under review. So you are able to get some of the information if you're kind of sneaky and start just Googling a lot out of this, which obviously I did. And there is a little bit more information, though, available in, they did do a proof of concept article in 2014, and that does give a little bit more information, but again, it's not sure if they have mentioned how this is kind of an evolving process and changing as they figure out a better way to kind of attack this problem. Our conclusion, so I mean, it's promising, but you got to do a better study than this. There's a lot of things where we said like, no, not really. We're going through that critical, our critical analysis tool. You know, but I think that there is a lot of potential here, which makes it very interesting in terms of something that's more easily accessible and potentially less expensive. But again, more study is required. Some key outstanding issues. So again, needs to be validated in the second independent blinded group. All right, you got to tell us when are you like that. Okay, you collect the billy just prior to or the exact same time as your total serum, because you can get that back within an hour, and again, you could potentially cause significant bias to your study if you don't take that into account. Now they're doing other stuff like, okay, what about HIPAA compliance with the data transmission of these pictures that are being taken of a patient and then being sent? What about identifying marks, other things, the security of that? And the overarching plan of this, the group that made this application is commercialization. And right now they're in the process of designing a second study and also having this, they're wanting this to be one of the first mobile applications that's approved by the FDA as a true medical device that providers could use in their offices. But a couple other things need to be taken even before that can actually be finalized, including, all right, well, what if you don't have internet? We need to be able to, is it possible to make an offline option? And not everybody has an iPhone. That's a very biased kind of group. So, and every different smartphone cameras are a little bit different, and they need to then adapt their algorithm to be able to be used in all of this. And then to make this even more complicated, the company that was made that kind of ended up producing this was actually just bought by Google. So I will say you will not find this app on the App Store. Just so I know many people have already looked and trying to find it. It does not exist. The app that was used in these studies was actually manually downloaded on each of their own individual iPhones because, again, they did not want this then to be used by parents and saying like, oh, look, I can, and when this is definitely still in a study process and has not been 100% validated. All right, let's go through it. So really quick, I think summary of teaching points of some of the more dry stuff that I did have to go through. Now, spin. All right, high sensitivity and a negative result, rule out the diagnosis. High specificity, positive result, rule in the diagnosis. Likelihood ratios, dependent on test sensitivity and specificity. All right, but that is independent of the prevalence, unlike positive and negative predictive values. Post-test probability, that's like where the big bang for your buck is in terms of looking at an individual patient and, and kind of trying to say how much is this really going to help me rule in or rule out this disease in this patient by using this test. And you need to have enough information to be able to determine their pretest probability, or at least the prevalence in that population, as well as then the likelihood ratios. And then you can easily use that cool Nomogram that's in the back of your hair lane that you thought you wouldn't have to use ever. Then 4 things just to remember about diagnostic accuracy studies. Is it a representative spectrum of their patients that they've used, that they've applied this to? Was the reference standard applied regardless of the index test result? So everybody got an independent and blind, which this study did not have, comparison between that index and that reference standard. And then did they tell us enough so that we could actually replicate this? Because that's a key part of the scientific method in terms of actually proving that it's able to be done independently. All right, a little throwback here from my very first journal club. Sorry. Anyways, questions? Yes.
So I noticed that 3 of the study authors are co-founders of the company that made equipment. And I was thinking about how they were a little fuzzy about how they selected patients for the study. And although it seems that actually a fair line for a study that was, that included authors from the companies that did the product.
Yes, there was a lot of definite, we were underwhelmed dramatically by the lack of information. Like there's so many things, so many questions. We're like, but what about this? What about this? It's like, I mean, we know things happen, things go wrong, but we just want that transparency, and we were not provided with that, unfortunately.
So many residents have heard me say this before. When articles go for publication, they're supposed to have peer review, and this is the opportunity of the reviewers to critically appraise the article and add their comments before it's published. And I feel that the reviewers could have perhaps done a better job of asking the authors to clarify these points before saying that they approve the publication.
100% agreed, and it's this is one of those where that initial title, I think, it gets people's attention. I mean, you're kind of like, oh, look at that, cool, and maybe you read the abstract and you say, oh, maybe that doesn't look so bad. Like that sounds actually like maybe it could be pretty cool. But again, this is that emphasizing the importance of going through this process and actually really reading and saying, well, definitely not as good as it initially appeared. Any other questions? Yes.
This is more of a question for some of the providers. We've asked Christine and Natalia so when we do transcutaneous bilirubin, do we garner income to the hospital for doing that in the newborn nursery, or is that bundled as part of any more package like taking a temperature?
You mean if the parents get charged for it? Or
Yeah, like the Medicaid, Virginia.
That I don't know, but I know we spend $40,000 a year on the PCB cap in the newborn nursery. Each cap is $6 and you cannot use it.
Yeah, I guess I'm just wondering, like, so if it's a smartphone and a card that's reusable on patients, we would lose that revenue. We're spending, however, $40K per annum to test however many thousands of babies a year. But I just wasn't sure if that, like, for the outpatient clinics, is this a revenue stream for us or not?
We've tried to get that information, and it's very unclear if we're breaking even or not. We're not making much if we're making anything because of the cost of the
Calibration strips.
Yeah, well, and we're going to use the tab. Ours doesn't have that, so it's just the cost of that initial layout for the machine. But the one at Rocky Mountain, where they have that. It's not reusable for each test.
I could see that hospital billing would not be transparent, but actually, Dr. Henschel, if your clinic is generating revenue from the PCB, you should see that in your clinic.
We have been working with our team to identify what that is looking like.
Yeah. I'm wondering too, like, if it's a loss of money to run this machine at an outpatient provider clinic, and that, I realize the study has bias, but it has potential too.
But there's also questions: are they going to charge you for the app? Is that price going to be per use?
Yeah.
Or is it going to be?
That's all those questions.
Yeah. So that may not save us, and that's certainly not going to be reusable patient to patient because unless you can sterilize them. And so I think there's going to be
of photo paper. My printer. Okay.
I have one question. What was the decision rule about positive tests being the camera PCD level greater than 13 compared to identify newborn with cancer? What was that?
We had to read that, honestly, many, many times before we were like, I don't understand what is going on. And that goes back to, so again, that's done based off of the transcutaneous, things that we've seen with transcutaneous bilirubin, that we need to we have to undershoot it because we're not going to, in order to make sure that we are really catching all of these cases, that we're not missing anybody, because it's not as accurate.
So you choose the 13 to represent?
Because that's what a study has been done that showed us that number is a pretty good number, and that's one of 3 different things that are detailed in the 2009 update to the hyperbilirubinemia practice guidelines that the AAP has put out. So.
Are you surprised that their ethnicity, skin color was so tight for all races?
Yes, and that is another good point, because there have been several studies that have come out showing how transcutaneous bilirubin oftentimes will overestimate values in the African American population in particular, and even in some of the Latino population. And which is one of the limitations of using transcutaneous. And so, yes, I do think that I was surprised, and I was glad that they at least gave us that subgroup analysis. But again, for questioning how people were chosen to be in this study, it makes you kind of question, okay, well, again, we need more data.
No, I think you raised a good point about standardization and lights on, lights off, flash, no flash. 6 inches, 3 inches, all these issues are critically important, need to be validated clearly before this can be finalized. The data almost seems a little too tight. I mean, this is a great case where it needs to be validated before it hits prime time. I agree, it has a lot of buzz, but it makes you wonder, was something left off?
Yeah, definitely. All right.
And then the within 2 hours.
Oh yeah, we attempted. Yeah,
And then what's magical about, like, I don't know, the rise of really and with 2 hours, I don't know.
Right. I would say, clinically speaking, and I think that you might get a slightly different answer depending on who you ask. I mean, granted, we're not talking about NICU babies here, where things can change extremely dramatically and very quickly. I would say, especially if we're thinking more outpatient, 2 hours seems reasonable, but that's, again, me just saying.
I think it'd be good also in terms of they excluded phototherapy. I think this would be, for the next study, would be ideal to look, you really want to include those kids and see how they pan out as a subgroup.
I agree.
Going forward, clearly.
Yeah, because...
But one thing, the argument that they're testing non-sick babies, and if you're really going to use it in kids, do we need phototherapy or not?
And you see the highest serum billy that was in that group of patients was 24.8, I believe, and we really talk about this significant risk for kernicterus, and again, when we talked about this, again, why do we do all of this stuff, is that greater than equal to 25. So we got close, but we didn't even really surpass that, so what are the limitations there, and it has not been tested in that, also in that sick, and that's one of the limitations in the spectrum of population that they looked at. Okay, I have one prep question, really quick. I guess we get to use. Anybody? Go. Ha-ha. This is a prep question for this year. So, really quickly, 2-month-old male presents to the emergency department late winter with a 2-day history of cough, rhinorrhea, decreased feeding, and progressive difficulty breathing. Based on the infant's clinical picture and the case mix you have seen recently, you estimate approximately 50% chance that he's infected with RSV. So you send a rapid RSV antigen test, which is positive. It is known that patients with RSV, because of course you just know this, are 5 times more likely to have a positive test than patients who do not have the disease. Applying the Nomogram shown, the post-test probability that he has RSV is what? And so I will let you think about it a little bit. It's hard to do it, because you don't have it in front of you. But go next, and this is more of a let's work this through a little bit together to show you what we're meaning. Did you go next? Yep. There we go. Cool little animations here. So 2 key things: approximately 50% chance that he's infected. So what does that tell? What is the pre-test probability? 5 times more likely to have a positive test. The positive likelihood ratio. So, next. Okay, 80%. Answer D. 50% actually people have gotten this wrong on prep, which is actually really high, which again, but this was actually incredibly easy, just utilizing these very basic principles. Okay? Next. Sorry, thank you for your patience. Sorry I ran a little late.
Thank you for listening in. Have a good